This conference will now be recorded.
Okay, so I'm sorry for the gap that we had for the last 2-3 weeks because of some problem with communication. I was on leave. Somebody was supposed to take the class, but nobody took it, I believe. Anyway, so continuing from the last time when we talked about the common principles of hernia, now we'll move on to the specific types of hernias. And the first part of the abdominal hernias we'll be tackling would be the groin hernias, right? Among the groin hernias, first the usual disclosures and acknowledgements, and you can find the list of books out here and the journals and the uh, papers which have been referred to, from which some of the information has been garnered. Okay, so starting with the groin. Now, when we talk about the groin hernias, it is not only inguinal hernia. So, groin hernia is a collection of four hernias that we commonly encounter. Among them, you can see here the direct hernia, the indirect hernia, the supravesical hernia, which is the extra supravesical hernia, and the femoral hernia. So together, all these four make what is now known as the hernia group. Okay, and this what you see out here is what is known as the Frouchard's orifice. Now, so this is the groin hernia equation that we commonly refer to now. Now, what is this Frouchard orifice, which we now understand when we were studying way back in 1980s, or rather late 70s? We didn't know, of course, it did exist at that time, but we didn't know what the Frouchard orifice was all about. But as more and more information were gained and the laparoscopic approach and the laparoscopic anatomy was understood in greater detail, we understood that there is a existence of a weak area. We always knew that, but that was now given a name. And this weak area had for its borders a muscle above. You see this muscle above? So this is the muscle, the arching fiber, the transverse abdominis and the internal oblique, and you got the bone. So above you got the arching fibers. Medially, you find that there is a lateral border of the rectus abdominis which gets inserted onto the pubic tubercle, lateral border, right? Inferiorly, you got the bony pelvis, the upper part, the pubic bone, and the Cooper's ligament on the iliopsoas line. And laterally, again, you got a muscle mass, which is the iliopsoas. Now, because these are all muscles and bones, so these are all properly reinforced areas. But the part which is lying in between these areas which were reinforced is a weak area. And that weak area was highlighted as the Frouchard's piriform myopectineal orifice. Why myopectineal? Because you got the muscle, that is myo, and pectineal because the iliopectineal line, you got the Cooper's ligament. So this now we understood in greater detail that we are talking about a weak, potentially weak area in the lower part of the abdomen, which we commonly refer to the area from where the groin hernias usually originate. Now, if you look at the Frouchard orifice from the inside and outside, so this is the outside view that I just now showed you in the last slide. If you look at it from the inside, the same thing inside. So you got these two vessels which are leaving the pelvis. So this is the pelvic view. This is the external view. So from the pelvis, these two vessels are leaving and they descend into the thigh. You got the cord structure out here. You got the iliopsoas muscle out here. This is the cord structure entering to the deep inguinal ring, right? And the iliopectineal line and the Cooper's ligament. Another figure depicting the same laparoscopic view or the pre-peritoneal view of the Frouchard's orifice. Now, the inner view, if you go through the peritoneum, right? Now, why this view has become important? For the simple reason that now more and more evidence is going in favor of a laparoscopic approach to hernia as the gold standard. Okay, now up to now we knew that Lakenstein's open hernia repair is the gold standard for treatment of inguinal hernia. But now there is a gradual shifting of the gold standard, and people are understanding that probably the laparoscopic approach would be slightly better. So if you have to go in for a laparoscopic approach, you have to understand what you are understanding externally. So if you look at from the interior or from the peritoneal aspect, so what do you find? You find that there are certain structures which are running from the umbilicus down into the pelvis, over which you got the folds of peritoneum. See this fold of peritoneum, fold of peritoneum, fold of peritoneum. Now, these define the three ligaments that we now understand. MN refers to median. N is N, median. MI or ML refers to medial, L. Okay. And the lateral umbilical ligament. So these are the umbilical ligaments. Why umbilical ligaments? We are running from the umbilicus down into the pelvis. So the median or the N ligament, we'll call it the MN ligament, is nothing but the peritoneal fold overlying the urethus or the obliterated urethus, which is either partially obliterated or totally obliterated. Okay. Now, laterally, go more lateral, which is the medial umbilical ligament, is basically the fold over the obliterated umbilical artery, which in the initial or the proximal part is more or less obliterated completely. It is only the distalmost part which remains as the cystic artery supplying, or the vesical artery, the superior vesical artery supplying the bladder. So the umbilical artery is obliterated except for the remnant, which forms the superior vesical artery. So that fold over the obliterated umbilical artery forms the medial or the ML umbilical ligament. And the lateralmost is the fold over the inferior epigastric vessel, which is the lateral umbilical fold known as the inferior epigastric vessel. So here you got the inferior epigastric, right? You see a fold running from here laterally. There's nothing but what is known as the vesicular fold, a peritoneal fold over a vesicular ligament. So what we have to understand is that these three ligaments from inside are enclosing three defined triangles. So you got the median triangle. This is the median triangle. So median triangle on the right, median triangle on the right and on the left, because we're seeing it from the inside. So both together form what is known as the combined median triangle or the supravesical triangle, from where you got the supravesical hernia. Now, the need to know these triangles is simple, that now we understand that these are triangles from where you have a particular weakening, and from the weakening, if there's a protrusion of the peritoneal fold, it will form a specific type of hernia. So if the hernia, if the weakening is in the median triangle, this is the median triangle, then it will give rise to what is known as the external supravesical hernia. If we have a weakening in between these two folds, that is the medial and lateral, that is the inferior epigastric and the umbilical, then you have what is known as the area from where you have the direct inguinal hernia. See here, the medial triangle and the direct inguinal hernia. And lateral to the inferior epigastric, you got the area of weakness where you got the deep inguinal ring, and that is the area which is known as the lateral triangle, area from where you have the genesis of indirect inguinal hernia. Okay, so that is the need to know these umbilical ligaments, and the need to know the areas from where you got the three different types of hernia. Now, if you go lower down, below the pubic tubercle and below the inguinal ligament, you got the area where you got the exodus or the exit of the femoral hernia. Okay, now this is the same thing, nothing different out here, except now the peritoneum has been mobilized. So we are now into the pre-peritoneal space. So this is the intraperitoneal view. See the intraperitoneal view, and this is the pre-peritoneal. So in the pre, you got the same thing. Now I have stripped off the peritoneum. So now we have those structures over which the peritoneal fold was being formed, right? So how do you correlate the pre-peritoneal view or the intraperitoneal view along with the external view? So if we look at these two views, then you see the corresponding correlation. So you have this median area. So when we are talking about the medial area, the median umbilical ligament. See the median umbilical ligament? So this is the external view we are talking about. This was the internal view we are talking about, right? And then you got the area between the medial and the medial triangle between the two ligaments. That is basically the obliterated umbilical artery here and the inferior epigastric vessel out here. That's the area of the direct hernia. So that is being depicted from externally out here. So you'll have the inferior epigastric artery lying lateral to it. We all know that direct hernia, the inferior epigastric artery is also lateral to it. And if you got the indirect inguinal hernia, the inferior epigastric artery is lying medial to it. So this is basically a corresponding pre-peritoneal view along with the external view, which will help you to understand what we are really talking about when we talk about the laparoscopic and we talk about the corresponding external view. This has been known since time unknown. since surgery started, but this is a recent, I think now more than what, 90s they started the laparoscopic hernia repair. So almost 30, 35 years old now. Okay. So this was the corresponding. Remember that this gives a very good depiction of what we're talking about from the external view and what we're talking about from the pre-peritoneal view. Now coming to the inguinal area and the inguinal triangles. So what is the inguinal triangle? Before we go to the inguinal triangle, let's talk about the inguinal hernia. Certain features which we already referred to when we talk about the common principles of inguinal hernia. So inguinal hernia is probably one of the most common hernias, accounting for almost two-thirds to almost three-fourths of the abdominal wall hernia, 65 to 75%. Lifetime risk of an individual in men is about 15 to 27% and about 3% in female. A single hernia, if you have a single hernia, the lifetime risk of you having the hernia on the opposite side is almost 33%. Male more common, 7 is to 1. Indirect more common, 2 is to 1. Bilateral in only 12 to 15% cases. The right versus the left versus bilateral, you have an incidence of 50 is to 40 is to 10. Okay. Now, the triangle that we're talking about, the inguinal triangle we're talking about, so you have a inguinal ligament and you'll have an area above the inguinal ligament and below the inguinal ligament. Below the inguinal ligament, we all know is the femoral area. Above the inguinal ligament is basically the suprainguinal, also known as the suprainguinal part of the Frouchard's orifice or the Hesser's triangle. The Hesser's triangle. Now, Hesser's triangle is basically nothing but that part lying between the conjoint tendon, the arching fibers here. See the arching fibers here. Then you got the rectus abdominis medially, and you got the inguinal ligament below, known as the Popper's ligament. Or more appropriately, if you want to define the triangle as an area which is a uniplanar structure, then you have to define the transalis facial arch, you have to define the Henle's ligament, and you have to define the ilipubic tract. For those who are uninitiated into the transalis fascia, I'm not going to go to the detailed transalis fascia, but just let me tell you one thing, and that is when you have the transalis fascia in this, you all know what transalis fascia is all about. It's a layer which is lining the inner surface of the anteabdominal wall. So if it's lining the inner surface of the anteabdominal wall, it is reinforced because I just now told you Frouchard's is an area which is a weak area. So it has to be reinforced. That reinforcement is by thickenings in the transalis fascia. And these thickenings are known as transalis facial analog, which you can find in the future slides. I'll just show you in one of the future slides, right? So this is basically what we're looking at in the inguinal area. I'll just refer to this again in a future slide. So just remember here that the Hesser's is nothing but the suprainguinal part, and that is the area when we are talking about the inguinal hernia, inguinal hernia, and the supravesical hernia, right? Femoral doesn't come in the Hesser's area. And then coming to the second triangle that we understand in the inguinal area, that is the Hasselbalch's triangle. We all know the Hasselbalch's triangle, and if you look at the Hasselbalch's triangle, it was defined way back in 1840. See this figure? 1840. And at that time, both the suprainguinal, Y suprainguinal, see this, the inguinal ligament. So the part lying above the inguinal and the part lying below the inguinal were all included in the Hasselbalch's triangle. Later on, this was defined or redefined, I would say, and as of today, we know the Hasselbalch's triangle is the inferior epigastric, lateral border of the rectus, and the inguinal ligament. That we understand is the Hasselbalch's triangle. But coming back, to geometrical, see the geoanatomic definition. Why the word geoanatomic? Because if you know your geometry, we all know that triangle is a uniplanar structure. Agreed? Now, if you got a uniplanar structure, it is one single plane, right? 2 dimensions only. It's not a 3-dimensional structure. But when we are defining a triangle with structures lying in 3 different planes, where is the deep epigastric lying? Pre-peritoneal. Where is the rectus abdominis lateral border lying? Most superficial area. Where is the inguinal ligament lying? In the external oblique. It's the lower part of the external oblique. So you can understand that all these 3 structures are lying in 3 different planes. Now, if you've got structures in 3 different planes, how can you define a triangle? You can't define a triangle in 3 different planes, right? So you have to have a definition which involves structures lying in one single plane. And for that, you have to take the help of a structure which is uniformly lining this whole area. This whole area. Is the internal oblique lining the whole area? No. It stops at the arching fiber. Transa abdominis? No. Stops at the arching fiber. External oblique? Very superficial. So the only structure which is continuous posteriorly is the transalus fascia. So if you can use structures or thickening the transalus fascia, you can redefine the Hasselbalch's triangle. And that is the geoanatomic definition of Hasselbalch's triangle, which defines the Hasselbalch's triangle utilizing thickenings in the transalus fascia. And these thickenings I just now told you are those which are lying in the Frucht's orifice area. So just behind the arching fibers, you got thickening in transalus fascia, which is known as transverse abdominis epineurotic arch. There's the arch. You got the lateral where you got the inferior epigastric. You got again a thickening on the transalus fascia, known as transalus fascial sling. Okay, and below, just behind the inguinal ligament, you again got a thickening of the transalus fascia, known as the iliopubic tract. So now let's redefine the Hasselbalch's triangle in a geometrical fashion. So geoanatomic definition of Hasselbalch's triangle is the transalus fascial arch above, the transalus fascial sling laterally, iliopubic tract below, and most medial you have the Henle's ligament. Okay, so that is the new definition of Hasselbalch's triangle. Now, this is a definition you may not find in many textbooks, but this is a more geometrical definition of Hasselbalch's triangle. Now, coming to the inguinal canal, right? Inguinal hernia, you have to know what the inguinal canal is about. So, it's extending from the deep inguinal ring to the superficial inguinal ring. We all know that. Agreed? The deep ring, we all know 1.25 centimeters at the mid inguinal point, opens upwards and outwards. The SIR, there is a slight confusion in the superficial inguinal ring, and the most of the anatomical tests will tell you it is lying superior and lateral to the pubic tubercle. You will find a number of references which say superior and medial to the pubic tubercle. Both of them, I would think, would be more appropriate. But if you follow the textbook of anatomy by Graves, which is considered to be the gold standard of anatomy, it says the pubic tubercle and the superficial inguinal ring, the relationship is that the SIR lies upper and lateral, superior and lateral to the pubic tubercle. So we'll follow that particular definition. It is so small, it does not admit the tip of the little finger, and both the margins of the DIR and margins of SIR are basically reinforced margins known as cruras. So the two cruras, medial and lateral, and the two cruras which are lining the deep inguinal ring. So here you got the cruras here and cruras here. Now what about the canal? It is an oblique canal. See this obliquity of the canal? It is about 3 to 5 centimeters in the adult. And what is more important is that it is only formed by the age of 5 to 6 years, which means what? It means that below 5 years, the DIR and SIR superimposed upon each other, because there is no canal, so SIR would be superimposed upon DIR. But as the child grows and as the abdominal wall growth occurs, the SIR gradually shifts down and down, and the obliquity of the inguinal canal is established. If you look at the roof of the inguinal canal, you have the arching fibers of the internal oblique and transverse abdominis. See the two muscles, you have the transverse abdominis and the internal oblique. Here lateral, from here they are arching, they arch like this to form these two muscles, that is the transverse abdominis and the internal oblique, what is commonly known as conjoint tendon, but I would say wrongly known as conjoint tendon, because it is found as a tendinous structure. The fibers are found as tendinous structures only in 5% cases, or less than 5% cases. That means the thickening of the internal oblique and external internal oblique and transverse abdominis joining together form a tendon is a rarity for the surgeon, is a common entity for anatomical people, right? So the arching fiber, we call the roof not the conjoint tendon, we call the roof arching fibers, the internal oblique and transverse abdominis muscle. The floor, we all know, is the inguinal ligament, which is the lower part of the external oblique aponeurosis. Medially, it is reinforced by the lacunar ligament. The anterior wall, aponeurosis external oblique, reinforced by the internal oblique laterally. So you see this reinforcement here. The transverse internal oblique laterally. This whole thing is from the anterior wall. See the anterior wall. But in the medial part, the anterior wall is only external oblique. Only. So this is the weak area we are always talking about. See the weak area? That is the weak area always talking about. And the posterior wall, the only continuous layer is the transalus fascia, which is uniformly lining the posterior wall. The internal oblique and the external oblique form the posterior wall only in the medialmost part. In a few percent of cases, the aponeurosa transverse abdominis muscle would form the complete posterior wall. Okay. Now, it is another depiction of the posterior wall. If you look at the conjoint area, so the rectus abdominis, the lateral border, you see transalis fascia here. This is the transalis fascia. You find the two layers of the muscle, that is internal oblique and transverse abdominis muscle, and these are arching fibers. And here you see the weak area by this arrow. So that is the Fruchard that we're talking about. This is the inguinal ligament. So this is another depiction of the same weak area of the conjoint area. Now come with the superficial inguinal ring. See the S, big S, because now we know that there are two superficial inguinal rings. Now what are these two superficial inguinal rings? We always knew that the SIR, I'll call it SIR now, is an opening in the external oblique aponeurosis. So far so good. Flanked by two cruras, I just told you that. But overlying the external oblique aponeurosis is a fascia known as the Glottis fascia, or the part of the Scarpa's fascia lying over the external oblique aponeurosis. We know that above the aponeurosis is the abdominal fascia, and then known as Scarpa's fascia. So the Scarpa's fascia over the external oblique in the inguinal area is the Glottis fascia. And when the cord escapes through the SIR, it has to have an opening in the fascia also. This opening in the Glottis fascia is known as the secondary SIR. And when the cord is exiting through the secondary SIR, it gains a covering from the Scarpa's fascia or the Glottis fascia, and this forms the external somatic fascia over the cord structure. Now, why the need to know the secondary SIR? The need to know the secondary SIR is that there are certain pathological conditions where anatomical discrepancy or anatomical problem in the SIR, secondary SIR, can lead to a number of diseased states. So if there's adhesion to the Scarpa's fascia, the Glottis fascia, there's underdevelopment of the Glottis fascia, or it may be absent. In all these cases, there could be a clinical problem of limiting the descent of the hernial sac into the scrotum, leading to what? Maldescent of the testis. So now we understand that one of the reasons for maldescent of the testis could be because of non-opening in the Glottis fascia, through which the cord has not been allowed to escape into the scrotum. So maldescent testis, testicular atrophies are two important clinical entities which are now being recognized as pathological conditions because of problem in the secondary SIR. Similarly, the deep inguinal rings. See the S here? So there are two rings, deep inguinal ring. We knew that the deep inguinal ring is nothing but an opening in the transalis fascia, right? We knew that, but with the two crura. But now we know that transalis fascia is not a single layer; it is three layers. So see this figure. You got the peritoneum and you got the membranous pre-peritoneal fascia, which also form the part transalis fascia, and the proper transalis fascia, the green and the blue. So the opening in the green is the regular DIR. The opening in the blue is what we know as the secondary DIR. And why the need to know the secondary DIR? Because the clinical importance is that when you're doing the mobilization of the cord, then until and unless you cut the secondary DIR, you're not into the proper pre-peritoneal space. See, until you go beyond this is the pre-peritoneal space, agreed? So until you cut this ring, you can't enter the pre-peritoneal space. And if you're not able to enter the pre-peritoneal space, then you have not done a proper mobilization of the sac of the direct or indirect inguinal hernia. So that is why it is important. And how do you recognize that you have entered through the secondary DIR? When you find pouting of the preperitoneal fat. So remember, the secondary DIR is an opening in the membranous layer of preperitoneal fascia. The primary DIR or the proper DIR is nothing but opening in the first transalis fascial layer. Now, I just show a very small video which shows you what we are talking about. See, this is basically the cord being mobilized out here. The sac, this is a sac we have. This is an open hernia being done. Can you see this layer now? Coming into view, the transalis fascia, the arching fibers internal oblique, and see that is being lifted. Fascia transalis. Now, see the finger going in. Can you see the finger in? See the pouting fat? So I've cut the secondary DIR. So until you cut secondary DIR, you cannot go into the preperitoneal space. See this? The pouting fat. That is the fat. See this fat? Now you can see that secondary being cut very clearly. So now this is the secondary DIR. See the margins of the DIR? Okay, so this is what I wanted to show you. So now that is proper understanding of the DIR. Now what are the contents of the inguinal canal? If you look at the contents of the inguinal canal, we've got the vas deferens, we all know that. Along with that, you got the nerves, and the only nerve which is a proper content of the inguinal canal is only one nerve, and that is the genital branch of genitofemoral nerve. Now you would say that we've been taught three nerves. Now, yes, agreed, iliohypogastric, ilioinguinal are the two other nerves. But look at the ilioinguinal nerve. Is it exiting with the cord? No. See, the ilioinguinal nerve is coming from here. I'll just show you the next slide. So, the ilioinguinal nerve never forms the content inguinal canal. Yes, agreed, it is exiting in the area of the SIR. Similarly, if you look at the iliohypogastric nerve is basically nerve which is lining or which is lying above out here, right? And above out here basically means it lies over the arching fibers of the internal oblique here. So iliohypogastric again is not in conformity as a content of the cord. So if you look at the content of the cord, it's only one nerve at the genital branch genitofemoral, only nerve truly running with the cord. Okay. What about the artery? The three arteries are there. Testicular artery, also known as the internal spermatic artery. The artery to the vas deferens from the inferior vesical artery, and the cremasteric artery, which is external spermatic artery from the inferior epigastric artery. So three arteries are there. One nerve is there as a real content. The other two nerves are there in the inguinal area, not as part of the content of the inguinal cord. The veins are there as the part of the inguinal cord, and these are the testicular veins which form the pampinoma plexus. You got the cremasteric vein, and you got veins from the vas deferens. So, three groups of veins. Pampiniform, we all know that. The cremasteric vein and vein from the vas deferens. Then you got the testicular lymph vessels, you got the autonomic nerves, and you got the processus vaginalis to complete the contents of the inguinal canal. Now, let's look at the nerve that we're talking about. See the iliohypogastric nerve lying over these are the arching fibers, the internal oblique, and behind the transabdominal. So this is the iliohypogastric nerve. Does it form part of the cord? No, it doesn't. See the ilioinguinal coming from more laterally over the internal oblique, and it forms a part of the cord only the medial part. So it's not a true part of the cord. Another figure showing the same thing. See the ilioinguinal, iliohypogastric, right? So they're not part of the cord as such. Okay. Now this just shows from posteriorly when they're exiting. Initially, it lies over what? Just behind the peritoneum, goes more laterally, it perforates and comes and lies in between. One is what? One is transabdominis, two is genital oblique. So in a short course, it lies between these two muscles. Then it perforates the internal oblique and then comes to lie in the inguinal area between the internal oblique and the external oblique. Right? So that is the course that these nerves take. See from here, exiting from where? The lumbar plexus. Initially retroperitoneal, then puncturing the transabdominis muscle, lying between transabdominal and internal oblique, and in the region of the antesupplex spine, it then perforates. See the perforation in between this part, internal oblique and the external oblique. See, very carefully and very nicely seen in this figure. Okay. Now coming to the cord coverings. To understand the cord coverings, just refer to this figure and you'll never forget it. So you got the inner covering or the internal spermatic from transalis fascia. See the transalis fascia? This gives a first covering to the inguinal cord known as the inner covering of the internal spermatic fascia. The middle layer, which forms the cremasteric muscle, is derived from the internal oblique muscle. See, you've got the internal oblique muscle. So transabdominis muscle does not give any kind of covering. Remember that. The transalis fascia gives the internal covering. The internal oblique gives rise to see these fibers coming out here? See these fibers from the internal oblique? So there's nothing but the cremasteric muscle. And the outermost, which until now we understood was coming from the external oblique, is not so. It is a layer from the glottis fascia, which is nothing but the scarpa's fascia in this particular area, giving rise to the external spermatic fascia. So remember, internal spermatic fascia or the inner covering from the transalis fascia, middle, which is cremasteric muscle from the internal oblique, and external sphenotic fascia derived from the glottis or scarpa's fascia. Right now, this is basically nothing which we already talked about in one of the previous slides, showing those thickenings in transverse fascia. You can see the arch, you can see the Henle's ligament, lateral part, you can see the Cooper's ligament, and you can see the sling. So together, this is forming the area from where you got the direct inguinal hernia or the Hasselback's area. Lateral to it, you have the cord, and this whole thing forms the Hesser's triangle, right? This is the area from where you have the escape. So see this pointer. That is the area from where you have the femoral hernia, right? Because what lies lateral to the femoral hernia? The vessels. So you got the extrailiac vessels out here. Okay, the artery and the vein. Now, the clinical importance of these analogs. Why do we know the transverse facial analogs? The need to know the transverse facial analogs is simple. Why? Number one, redefine the Hasselback's triangle in a geo-anatomical fashion. Number two, re-explain the shutter mechanism. And I'll just tell you what the shutter mechanism is all about. The Cooper's ligament repair. We now understand the Cooper's ligament repair is basically nothing but the ilio-pectineal ligament with the transverse facial arch. So that means we are doing a repair which is totally and purely involving transverse fascia. It gives added strength to the weak wall of the inguinal canal, and the transverse facial thickenings, they hold the sutures better in any kind of repair procedure. So these are the clinical importance or applied importance of understanding these analogs, right? Now, before we go further to understand the shutter mechanism, before we go further, now let's just talk about the pre-peritoneal view. I think we already talked about this figure. I'll not go back to this, but just to understand, this is another figure that I told you about, the correspondence of the pre-peritoneal and the umbilical ligament and the external view, the correlation between these two. But what else we need to know about the pre-peritoneal space is the Retzius space. Now, shutter mechanism are purposely given up at this point. I'll talk to you when we talk about the causes of inguinal hernia. We'll refer to that again. But coming to the pre-peritoneal anatomy is again very important, because I just now told you that understanding that the gold standard, the new gold standard is probably for time to come would be the laparoscopic approach. So we have to understand what we are talking about. So when we talk about the pre-peritoneal area, we talk about two areas which are of utmost importance. One is the Retzius space or the retropubic space, wrongly known as retropubic. I'll just tell you why. And the Bogrov space. Now, retropubic space initially, when we were studying, was defined as the space lying just behind the pubic bone and in front of the bladder. But now we understand the Retzius space extends. So that means this was the space that we were talking about initially. But now we understand Retzius space extends right from the umbilicus down to the urogenital diaphragm. From here to urogenital diaphragm. Urogenital diaphragm is nothing but the neck of the bladder. See the neck of the bladder here? So this forms the urogenital diaphragm. So everything from here to here is basically the Retzius space. What are the lateral extensions of the Retzius space? In the pelvis, obviously, you got the lateral wall. The lateral wall of the pelvis on either side forms the lateral margin of the Retzius space inside the pelvis. But what about above? Above, probably the obliterated part of the umbilical arteries, which is what? The ML ligament. Remember, ML ligament. Now, there are certain descriptions where the lateral boundary of the Retzius space is considered to be the lateral umbilical ligament. So that's why this blue line and this is the yellow line. So below in the pelvis, the lateral boundaries are very clear. It has to be the bony boundaries of the pelvis. But above the pelvis, as you come out of the pelvis, that means we are talking about this part. We talk about this part. So what forms the lateral boundary of the Retzius space? It is either up to the infraepigastric or the lateral umbilical ligament, or the obliterated part of the umbilical artery, or the medial umbilical ligament. So that is basically the retropubic space. Now, the other thing you have to remember is that the retropubic space or the space of Retzius is laterally continuous to another space which is known as the Bogrov space. So the space lying out here, lateral to it, is known as the Bogrov space. I'll just show you. Now, so now we know the upper extension, the lower extension, the lateral extension. Upper umbilicus, lower urogenital, lateral bony boundary of the pelvis and of the pelvic girdle, and above either the lateral umbilical ligament or the medial umbilical ligament. Agree. But what about the anterior? Where is it really lying? Is it lying just behind the muscle? Is it lying behind the peritoneum, lying in the preperitoneal plane? So see here, see this figure, and this is slightly more beyond your scope as a UG. It's more for the PG, but there's no harm in knowing what we're talking about. So there are two definitions of retropubic space of Retzius. One, whether it is lying between the preperitoneal fascia and the bone, see the yellow, or it is lying behind the preperitoneal fascia and the bladder, see the purple. So there are two definitions to it, and that becomes all the more important when we talk about the preperitoneal approach. I think at your level, this is more than enough. You just understand that the retropubic space is a space which is lying behind the anteabral wall and the bony pelvis. This is another space. See this retropubic space of Retzius, lying between the fascia and the bladder. This is a dissected specimen, and you see the Cooper ligament out here, the boundary wall, that is the bony pelvis. See the bony pelvis, pubic symphysis, and the bony pelvis. This is a preperitoneal view. We are seeing it from the inside, a preperitoneal view, right? So inside the lateral boundary and above the lateral boundary, that is different, right? Now, what is the clinical importance? Why do we need to know the retropubic space? Because I just now told you that below it is the lateral boundary of the bony pelvis, that is the pelvic girdle. Are there important structures there? Yes, that is the most important part. That when you're trying to dissect out the peritoneum, this whole space has to be created because you want to put a mesh there. In any kind of preperitoneal repair, it has to be a mesh repair. It cannot be a stitch repair. So you have to put in a mesh. And mesh basically means what? It has to cover the weak area. So if you're going to cover this weak area, it has to extend below the weak area. So that means you have to dissect this particular area. And dissection of this particular area is the problem with the Retzius space. That is the clinical importance. So it has to be adequate. Why adequate? Because the mesh should be fitted inside. And it has to be very, very careful. Why? Because normally you see all these structures out here, the nerves, the arteries, and the veins. So what are the vessels? See this group of three: the obturator nerve, the artery, and the vein. The most constant lateral structure lying in the lateral wall of the pelvic girdle, right? So normally you got the obturator vessel. Above this, what do you find? You find the external iliac artery and external iliac vessel. See my pointer, laser pointer. You find the vein and the artery. So these are very important structures. Why? Because the dissection has to be done up to this place. You have to strip it up to this place. The mesh has to come up to this place, right? Now you don't need to dissect further down. You don't need to dissect this area. So normal dissection involves this particular area. So normally I'm happy that I've got this, but I'm not very happy in certain instances. Why? Because in more than 50% of cases, there may be abnormal vessels. Now, look at the dissected specimen. You find the external iliac vessels. See this? Right. You see this obturator nerve and the obturator artery in this particular here. See the obturator vein, the obturator nerve. Now, so you see a vein out here. You see a vein out here. You see a vein out here. Is there a vein normally out here? Artery normally out here? No, sir, it's not. Remember one thing. Whenever we talk about a pre-peritoneal, there is no vessel. There is no vessel which should be running like this. Remember this, across the pubic bone. No vessel at all. It should not. If there is any vessel running like this across, see this, running across the pubic or the pubic bone, it is an abnormal vessel. And that is what we talk about. See this aberrant obturator artery, aberrant obturator vein. And if you perhaps manage to damage these vessels, then you've had it. Why? Because the bleeding doesn't stop. And when you're doing a surgery, because the carbon dioxide pressure, you're not able to see the bleeding from a vein. Once the collapses, the carbon dioxide pressure relieves, then the bleeding starts, the oozing starts, and post-operatively, you have done a very good surgery, you're very happy, you send the patient back to the ward, and you get a call from the ward within half an hour that the blood pressure is dropping, and you can't understand what has happened. There was no bleeding at all. What had you done? You had managed to damage one of the veins, which have now started oozing, and the patient goes into shock, and that is why this is known as circle of death. Circle of death. See the wire, the circle that I've drawn, the yellow circle. That is why. So remember, when you're talking about the normal structures that are in the lateral part, we are very, very careful that we don't damage the obturators, we don't damage the external iliacs. Rarely, or rather, abnormally, more than 50%, I may find an accessory obturator, artery or vein, I can also find atypical arteries and veins running up to the bladder. This is the preperitoneal bladder. What else can I find? I can find a retropubic branch of accessory obturator or artery or obturator vein. I can also find an accessory pudendal 10% arising from internal iliac. Now, where is the internal iliac? This is the internal iliac. There may be a vein running from here, running up to this particular area, which is an accessory pudendal. There's a routine pudendal now. See, routine pudendal. But there could be an accessory pudendal running like this. So if you got accessory pudendal vein or artery running like this for 10%, again that may be fraught with danger when you're doing a dissection out here. Right? So this is basically the Retzius space, clinical importance. And you see this is the pubic bone. You see the pubic symphysis. This is a pubic bone. You see the normal. See, I told you no vein should be running like this. So this is a vein which is normal vein, iliopubic vein, the pubic tubercle. But see a vein, a very, very thick vein running like this across the pubic bone. Is it normal? No, sir, it is not normal. It is abnormal. And that is an accessory obturator vein. If you damage this, now where is the obturator foramen? Here. Where the infraepigastric? Here. This is the vein coming from infraepigastric into the obturator foramen. So it is an accessory obturator vein. So please do not damage this, otherwise this patient will not survive. So this whole thing is a Retzius space. Now coming to the second part of the space. So sorry. And that is the subinguinal space of Bogros. To start with, initially when Bogros space was defined for the first time, it was a very, very small space. It was only 1.3 to 1.5 centimeters. See, 13 to 15 millimeters. 1.3 to 1.5 centimeters. And only 4 to 6 millimeters thick. A very, very small. And why was described? It was basically described as the area or the termination of external iliac vessel. And Bogros was a French scientist and who defined this particular area as an area through which you can directly access the terminal part of the external iliac artery or vein. But the present day Bogros space, that's why it's written as new Bogros, is the whole space lying lateral to the infraepigastric. Infraepigastric, the whole space lying lateral to it and slightly lying medial to it. See, what is this? This is basically the medial umbilical ligament. And this is the infraepigastric ligament. So this whole area lying lateral to the infraepigastric in white, and the yellow area which is depicted lying medial to the infraepigastric is the whole area which we now understand as the Bogros space, as a lateral extension of the space of the Retzius, right? Why this yellow area, which is the Bendowitz circle with veins? Because this is an important area where you got, see this figure, lateral border, the stippled line is lateral border rectus. You have a number of veins draining the rectus muscle, that is the rectusial veins. Now, where these veins draining, they form a common vein and they contact with what? The infraepigastric vein. So, you have the rectusio-epigastric communicating vein. And they would also communicate with the iliopubic vein out here. I showed you the iliopubic vein here. See the iliopubic vein? That is the vein out here. So that is again a communication channel between the two. So this whole circle is known as the Bendowitz circle, right? So this Bendowitz circle is lying in just superficial, the preperitoneal plane lying superficial to the peritoneum and behind the first layer of transverse fascia, right? And I told you what are the components of Bendowitz circle. The other contents of the Bogros space. So this is the very important content of the Bogros space. The other contents of Bogros space, which include what? The deep circumflex iliac vein, the testicular veins, and the differential vein, which is the pampiniform plexus. That means the vein of the vas deferens and the pampiniform plexus and the vesical plexus. The applied importance is that when you're dissecting this, you're going to strip off the peritoneum in a TAPP repair or TEP repair because you put in a mesh out here. And if you manage to damage any of these veins, it gives rise to very troublesome bleeding. So you have to be very, very careful that these veins lying in the preperitoneal space are not to be damaged when you're doing a mobilization of the preperitoneal space, as in DAPP, TEP, DAPP for ventral hernia repair or extended TEP repair, any of these, right? So this preperitoneal space dissection, you have to remember a number of important points. See this figure just to make you understand what this figure means all about. So you have the peritoneum, the fascia transversalis, and 3 layers of the muscle. See the 3 muscle layers and the fascia transversalis. So this is basically the true preperitoneum, right? Now you see the peritoneum as a thick layer, a yellow and a green. that shows you basically the area which is the membranous part of the pre-peritoneal, which is now known as the second layer transalus fascia. So you're going to do a dissection in this particular area. If you're doing a dissection in this particular area, see, the vessels would not be damaged if you do not damage the transalus fascia layer number 1. So while dissecting, remember one thing, fat always belongs to the peritoneum. So if you're doing a dissection, the correct preperitoneal space, there should be absolutely no bleeding, no oozing. You're doing dissection, you're very happy, you are in the absolutely correct plane. But you have even a minor amount of bleeding or oozing, remember one thing, that your preperitoneal dissection is fraught with danger, you are in the wrong plane. Right? So the vessels should be toward the abdominal wall, the fat should be posterior toward the peritoneum, and that is the layer where you have to go in for dissection. This is the layer. You have to dissect out here. See the fascia transalis lying anterior, peritoneum posterior. So this is the layer of dissection. If you do a dissection in this particular layer, you're going to damage the vessel. Right? So if the plane is correct, bloodless dissection. And how do you identify this plane? I just now told you bloodless. And number 2, you will find what is known as the cow web appearance. What is a cow web? See this? See this? Like a web. So it's a cobweb appearance, also known as a woolly appearance. This is known as the woolly appearance. So if you have got this kind of appearance, see, there's no bleeding. This is an actual dissection photograph. There's no bleeding at all. So this is basically an area. See this cobweb or the woolly appearance? This shows you are in the correct plane, right? Inferior epigastric vessel should always be kept sticking to the anterior wall. They should not be allowed to fall away from the wall. If you are allowed to do so, that means you are in the wrong plane of dissection. So that is a very, very important part when you're doing a pre-peritoneal dissection for a TAPP or TEP repair. The other thing you have to remember when you're doing a pre-peritoneal dissection are the nerves which are there in this particular area. Another figure which is very important, and you see there's a genitofemoral branching into two, the femoral branch and the genital branch. See the genital branch entering into the inguinal canal, right? So as I told you, this is the only true part of the inguinal cord, only one nerve, and that is the genital branch, genitofemoral. The femoral branch escapes from under the inguinal ligament. See, it's lying below the inguinal ligament into the thigh. Slightly lateral to it is what is the lateral femoral cutaneous nerve. Then slightly lateral, you got the ilioinguinal and iliohypogastric nerves, right? So these are basically two nerves which are coming from here. Then there would be, see the layers of the muscle, transabdominis, internal oblique, external oblique. So perforating the transabdominis lying in between the two, and at the ASIS or the anterocephalic spine, perforating the internal oblique and then lying in between these two. Okay, so because you're going to do a dissection here in a pre-peritoneal dissection, so you have to be very careful about two nerves, the lateral femoral cutaneous and the femoral branch of the genitofemoral. What about the femoral nerve lying below? This is not encountered if your dissection is correct. It is only when you're trying to mobilize the psoas muscle, which you should not in a pre-peritoneal repair. It is only then that you're going to encounter the femoral vein. If you're seeing the femoral vein, remember you have dissected very deep, which you should not have done. Okay, so the applied importance of recognizing these nerves, basically, the course is written. I'm not going to repeat it. You can go back to this lecture and you can see what the course is. But what you have to remember is the applied importance of these is, please do not damage these two nerves, that is the lateral femoral cutaneous nerve and the femoral branch genitofemoral nerve. And the catch is that if you do not dissect under the psoas fascia, remember these nerves are lying in between the psoas muscle and the fascia of the psoas muscle. So please do not dissect the iliopsoas fascia. See the fourth point. Please do not. The moment you start dissecting this fascia, then either you're going to damage these two nerves, or you're going to damage the femoral nerve, or you're going to damage, if you do a more lateral dissection, you're going to damage these two nerves, right? So please do not damage do not dissect under the fascia. Please do not try to show the nerves. It's not necessary that you have to show the nerves to show a very good dissection. It's not that. The other point which is very important is that you can find that these nerves are going below the inguinal ligament. Agreed. And that is why when you put in a mesh, the mesh has to be fixed to the anterior wall. And for that fixation, either you apply sutures or you apply tackers, which are known as these are tackers which are either absorbable or not absorbable, which make the mesh stick to the anterior wall. So where should you apply the tacker? Now, if you're going to apply the tacker below the inguinal ligament, you're going to damage the nerve, and this patient is going to come to you in the post-operative period with persistent neuralgia. So what is important in these instances is that when you're applying a tacker, no tacker should be applied caudal to the inguinal ligament. But that is not enough. Why? Because in 30% of cases, you can find an aberrant branch from the lateral femoral cutaneous or an aberrant branch from the femoral branch genitofemoral running over the inguinal ligament cranial to it. So in 20%, the nerves of branches pass through or above the ilipubic tract or the inguinal ligament. So remember that the first tacker to be applied should be at least 2 to 3 centimeters cranial to the ilipubic tract. You'll understand this better when we talk about the actual preperitoneal repair, either TEP or TAPP, right? So this is basically the preperitoneal space or the space on nerves. Now this is basically a dissected specimen. You can find the lateral nerve of thigh. You can find the femoral branch of the genitofemoral nerve. See, it is branching. The genital branch and the femoral branch, right? So this is basically the right side. So this is entering the deep inguinal ring is somewhere here. So genital branch entering the deep inguinal ring, the femoral branch going superficially. So to make a correct orientation, the inguinal ligament is somewhere here. So the femoral branch is going, exiting, lateral nerve exiting. This iliac or the iliac psoas muscle. If you go further laterally, you can find the ilioinguinal nerve, and more laterally the iliohypogastric nerve. So this is the dissected specimen, and this is a corresponding figure out here. You can understand this better out here. Same, absolutely same. See this branching, the branching here. Genital branch, femoral branch. This is the femoral branch, this is the genital branch. Genital femur, genital femur. Then you find the lateral nerve of the thigh, lateral nerve of the thigh. Further laterally, ilioinguinal nerve out here. This is the ilioinguinal nerve out here, right? So that is basically the figure that I wanted to show you. This shows a correct dissection. So see, the fascia is there. The fascia has not been. That is why the nerves are not seeing very clearly. It is just the overlying fascia that you can find out here. So that brings us to the critical anatomical spaces when you're doing a preperitoneal dissection, and you got the three critical anatomical spaces. That one which is lying lateral, which is, so this is the pelvis, this is the area of space of Retzius. I just now showed you that the yellow figure, so that this the corona mortis. Why? See the accessory artery, accessory obturator vein written out here. So this is, if you manage to damage any of these, you're going to lead to what is known as death. Excessive bleeding leading to death. That is why it is known as corona mortis. The name is corona mortis. Then you've got the two structures, the vas deferens, and you've got the external iliac vessels. The triangle in between is the triangle of doom. Why? Because, sorry, the testicular vessels, and you've got the vas deferens. What is lying underneath out here? The external iliac. So this is the area. See this triangle in blue? There is a triangle in blue. So this, what is lying in the floor of the triangle is the external iliac vessel. So if you manage to damage them, the patient is doomed. You're doomed. That's why triangle of doom. And laterally, I just now showed you what is lying lateral to it. All these nerves, all these are the lines. So this is the vessel, and lateral to vessel is basically what is known as the triangle of pain. So this is the triangle of pain. Why? Because if you damage any of the nerves in the lateral part, you would be having a persistent neuralgia in the post-operative part. I think we'll finish here, and next time we'll talk about the clinical features and the treatment modalities of inguinal hernia. And just to, before I sign off, I would just request you, whosoever was there on the mic, please from next time kindly switch off the mic. Thank you for your time.